Hi, fabulous caregivers. I miss you so much. This is Karen, and this is a recording of the caregiver meeting that we should have had in person, but thank you so much to COVID 19 that we can't. So I'm going to be doing this over this video or voiceover recording PowerPoint. Today, I want to talk about the scope of services for all of us for home instead senior care. Some of them you know certainly by hand, you know absolutely not, we can't do that. But some of them I thought were kind of interesting, and we thought together as a group it would be really good to go over the scope of services. After you do this, or after you review the scope of services voiceover, then you'll take a quiz and send that in. And hopefully, I'm really hoping that we can get together very shortly and I could see your faces. But thank you once again for providing amazing care to our clients. All right, now I'm going to try to figure out how to advance this. There we go. So the first thing that I want to talk about is some of the activities of daily living in terms of bathing and skin care. So we know that with bathing, we can assist a client for sure. Getting into and out of the shower. I'm not sure we have any client who like literally puts their foot over the bathtub and gets into the bathtub. But we can do that, and we can certainly provide a bed bath when the client is completely confined to bed and can only help very minimally. Now, what's important with what we cannot do is providing a bath or a bed bath to somebody who has a huge wound that requires adjusting change either before, during, or after the bath. So if we have any clients out there, let's just say they have a huge wound on their sacral region, we would not be able to change that dressing, let's say for instance if it got wet. So that client would only be required to have a bed bath of the front side of them. As far as skincare goes, definitely washing the skin with soap and water, rinsing it, applying medicated and non-medicated lotions to the client's skin, which we absolutely can do. Again, the point that we cannot do would be skincare that the client has a huge wound that has the possibility of getting saturated. Maybe it's a wet to dry dressing change, something like that. We would not be able to assist with doing that wound care. That would entail having a nurse from a home care company, skilled nursing that would come in and take care of that client. Hair care, same thing. We could definitely maintain the client's hair, combing, brushing, styling it, flat iron, curlers, anything like that. One thing we cannot do is cut the client's hair under any circumstances. Moving on to oral care, we can definitely assist that client with dentures, brushing their teeth, giving them little toothlets, whatever it might entail. What we cannot do is suction the client's mouth. There are very few clients that we've had, I know in the past 12 years that I've been here, that have had suction at the bedside, and that would entail the family member doing that or the client themselves suctioning their own mouth. As far as nail care goes, we can soak their nails, we can file the nails, push back the cuticles. We cannot absolutely, under any circumstances, trim the client's fingernails or toenails. And the reason for that being is if we accidentally cut the skin and the skin gets infected, especially if they're a diabetic client, then we would be liable for the complications that can happen. Shaving, we can only shave a client with a electric razor. We cannot use a straight edge razor to shave the client. And again, the reason being is because if we accidentally cut that client's skin and it gets infected, we would be liable for that. Dressing. So we can assist the client with dressing. We can help them put compression stockings on, or those stockings that are really tight and they have varying degrees of compression. Those we can put on either the ones that are bought over the counter, and typically the ones that are bought over the counter have 12 millimeters of pressure or less. Those that are obtained with a physician's prescription are 14 millimeters or greater. And a lot of times it's with clients who have congestive heart failure, they have vascular or arterial issues in their lower extremity. So, what you might notice is that their legs might be brown, they might be shiny, they might be hairless, anything like that. And that indicates to you that they have arterial or venous issues. What we cannot do is assess or determine a client's need for those compression stockings. So, saying that, gosh, I think you would really benefit from these. Why don't you go out to the store and get some? We cannot do that. There are certain times where they would provide a complication to a client. Let's say, for instance, if they had a DVT or a deep vein thrombosis, and we put those compression stockings on, we could facilitate the movement of that embolus, and that patient could have a stroke, they could have a heart attack, it can go to their lungs and cause a pulmonary embolism. Okay, incontinence care, that's a big one. Certainly, we can assist them going to the bathroom, using a urinal, using a bedpan, changing the diapers or the Depends that they wear. If they have a Foley catheter, we can empty that catheter. We can switch over the catheter bags from the bedside bag to the leg bag. That's not a problem. If they have a colostomy or a urostomy, so one is to the colon, one is attached to the bladder, we can definitely empty those bags. What we cannot do is give somebody an enema. We cannot give them a suppository to help relieve their constipation, or maybe they're impacted. They haven't had a bowel movement in weeks. Maybe it's been a month, and we cannot help with that in any way. That would be considered invasive, and there can be a lot of complications that can occur just giving that client an enema or a suppository. The other thing about colostomy or urostomy care is that we cannot monitor the site of what that ostomy looks like. So knowing that that ostomy should be bright red is a good thing. If it's blue, that means that there's not a blood supply, that we should contact somebody. Family members or nursing staff need to be able to observe the skin for any breakdown or monitor that ostomy site. The other thing also that we cannot do is replace the ostomy bag or replace the wafer that goes around that site. Feeding in general, certainly we can help feed a client, making sure that they are sitting upright when we are feeding them. Never, never, never feed a client when they're even 30 degrees or 40 degrees. They should be sitting upright. We want to facilitate movement of food down into the esophagus, into the stomach. We certainly don't want that client who can't protect their airway eating and take that risk that that food might go into their lungs and cause a pneumonia. We can also add thickener to liquids, either to make that liquid, their coffee, their soup, whatever it might be, honey or nectar thick. Definitely, if we have a client who is a client where there is a high risk for choking, that would be a client that we would be unable to feed. Now, if the client is able to not choke because they have thickener in their food, that's a different story. We can feed them with the thickener, but clients cannot be fed if they are at high risk for choking, or any little bit of liquid that is water-like consistency, coffee, milk, tea, anything like that. The reason being is that because that instead of going down into the stomach, it would go down into their lungs. We also cannot feed a client when there's medication in the food. So let's say, for instance, the client cannot drink or take their medication, they can't swallow the pills. We cannot open up that capsule, put it in applesauce, and feed it to the client. They would have to be able to do that themselves, putting that pill in yogurt or pudding, anything like that. They would have to be able to feed that medication to themselves. Feeding devices, which would be a PEG tube or a Dobhoff tube. So we can definitely use or help the client when they have a PEG tube, and that's a percutaneous endoscopic gastrostomy tube or a PEG tube. So we can feed into the PEG tube. The PEG tube is a tube that almost looks like a Foley catheter that comes out of it, and it is inserted directly into the stomach. It is sutured on the outside and goes right in there. So when that client has a PEG tube, we can definitely help feed them. Now, if it is attached to a pump and we have to manipulate that pump or program the pump, we can't do that. A lot of times, if somebody is getting fed through a PEG tube or a G tube, a lot of times we'll call it a gastrostomy tube, we can help them if the tube feeding is going in by gravity drainage. So the tube is way up high, it's just dripping in very slowly because it's going in by gravity. We cannot feed somebody who had a tube inserted previously within the first 2 weeks. There's too much risk of contamination that can take place or injury that can happen. We cannot provide nourishment or that tube feeding through a syringe. So sometimes you'll see them attach a syringe to that G tube, pour the tube feeding in there, hold it a little bit upright, and it goes in by gravity drainage. We can't do that. It has to be attached to the tube, to the tube feeding, and go in by gravity that way. We cannot use a syringe to extract gastric contents. So sometimes we want to make sure that the tube is in the stomach and not in the lungs. And in the hospital setting, we would remove the contents of the stomach and we would test it to make sure that the pH is very acidic, knowing that that would be in the stomach. We are unable to do that as caregivers for our clients. So they either need to have a skilled nurse at the house or a family member that would take on that responsibility. Let's see. Continuing on, we can never, ever, ever insert a feeding tube or change a feeding tube. We cannot monitor the insertion site for where that tube is. That would be monitoring or assessing. That would be a lot of responsibility, and that responsibility would have to fall to a skilled nursing professional or a family member who's willing to take that responsibility. Okay. Helping a patient ambulate or evaluate what their gait is. So we can definitely help a patient ambulate by offering our arm or holding on to the client or helping the client to get seated. We can use a gait belt. If they have a regular belt that is through the belt loops, we can use that. We can help them use a walker, a wheelchair, a cane, anything like that. What we cannot do is help a client to stand or pivot bearing their full weight. Our clients have to be able to bear their own weight. If they're getting out of bed to a wheelchair or chair to bedside commode, anything like that, we should not have any clients that we do a total lift on. If we have a client that is a total lift, we need to get a Hoyer lift, and if it is a Hoyer lift that client needs to use, then it absolutely needs to be done by two people. And two people would be two caregivers that are employed with Home Instead Senior Care. It could be our caregiver and a family member, anything like that would be okay, but it absolutely cannot be that you would use a Hoyer lift all by yourself. Let's say, for instance, the family member or the wife or the daughter or whatever is the one who's always helping you get the client into the Hoyer lift. And today they say, okay, I'm going to run out to the store and you can get my dad in the Hoyer lift. And so you're stuck. Absolutely cannot happen. You could be injured. The client can be injured. Clients have fallen out of Hoyer lifts before. Personnel have been injured by them. So it's an absolute must that you use two people, that we employ or we use two people when using a Hoyer lift. Transfers and turning and rolling. Again, we can help use a mechanical lift, that Hoyer lift or that Sarah lift. That Sarah lift is used where the client still has that really good upper body strength and can hold on, and we're sort of turning them to sit them on a bedside commode or sit them in a wheelchair, anything like that. So we can do that. Make sure that you are not lifting a client completely and bearing all their own weight. That's too dangerous. We don't want you to get hurt. That client has to at least bear their own weight on one of their extremities, on their legs, and to move them. We can also help turn or roll a client in bed as long as there's no serious injuries, as long as there's no serious post-surgical complications. Let's say, for instance, the client is a total hip replacement, comes home. We can help move that client. Absolutely, we're not going to turn that client on the hip that they had surgery on, but we can help turn that client on the other side and making sure that they are getting turned every 2 hours while in bed. Again, if there's any post-surgical complications, let's say the client did have that right hip replaced, but on their left hip now they have an open wound or an open sore, we're not going to assist that client rolling at all because we can't move them to the right side and we can't put them on that side that has the wound, that open wound. Okay, exercise or physical therapy. We can definitely assist the client with encouraging them to perform their physical therapy, and that would be physical therapy that was already prescribed for them by a licensed physical therapist. We need to remind the client it's time to do the physical therapy. We cannot move the client's body parts for them or something what we call a passive range of motion. So we can move their body parts, their extremities, their arms, their legs, and move that for the client. The client has to be able to move their extremities by themselves, although we can be encouraging. Okay, Mr. Jones, it's time for you to do your arm lifts or your leg lifts, anything like that. We cannot complete a whole physical therapy routine for the client. That is only done by physical therapy. They can write those exercises down, and then our job would be to remind them, you have to do physical therapy twice a day. Okay, it's the time in the morning when you normally do it. Okay, it's the time in the afternoon when it's done. The other thing that we cannot do is assist a client with a TENS unit. Sometimes you'll see a TENS unit being utilized for chronic back pain or chronic muscle pain. We cannot assist with that because what's happening is this is the unit that goes through their skin into the muscle, but it's stimulating the nerves to that muscle to increase motion and to take away the pain. So we cannot assist with a TENS unit with a client. Okay, rubs or massages. So definitely we can assist a client by gently rubbing their skin for circulation purposes, to apply lotion. A lot of times we'll have clients who need that lotion applied to their lower extremities. Their skin is very dry. They get that Sarna lotion put on, anything like that. We can certainly do that. What we cannot do is give the client a massage, and certainly not a deep tissue massage, which, we all know that feels great, but there can be a lot of complications with the elderly client in giving them a massage. Respiratory care, we can definitely take care of clients who have oxygen therapy. We are unable to change oxygen tanks or regulate the pressure. If a client is on 2 liters of oxygen, we can certainly make sure that the oxygen dial is set at 2 liters, making sure that that's where it is. We cannot increase or lower the oxygen concentration. That would be something that the client would have to be able to do themselves or the family. There are times, for instance, there's times when a client might have something called COPD, which is that chronic obstructive pulmonary disease. They might be on oxygen because that increases their quality of life. But one thing to understand with COPD is that too much oxygen can knock out that client's drive to breathe. Because somebody who has COPD, their drive to breathe is a low oxygen level because they're holding on to too much carbon dioxide. And so let's just say, for instance, your client became acutely short of breath, you were worried, you flipped up that oxygen, and all of a sudden they're getting so much oxygen they're not used to it, you can knock out their drive to breathe. So if they're on a certain liter per minute on that oxygen, definitely keeping it at that point is what we can do. Knowing that that client who's on oxygen should not be around anybody who's smoking. They certainly shouldn't be smoking themselves if they have oxygen on. They shouldn't be around an open flame. They shouldn't be around a stove, anything like that. Oxygen is combustible and can start a pretty serious fire. I've seen it happen. Tracheostomy care. What we can do with a client who has a tracheostomy is help the family just get supplies ready. We cannot, absolutely do not do trach care. We can't do suctioning. We can't remove that inner cannula. We can just monitor that site and be assured that that client is breathing in and out through their tracheostomy. Sometimes clients or family members will say, here, let me show you how to suction, that if my mom ever needs suction, you can do it. We absolutely cannot. That is considered an invasive procedure, and we can do more damage than good by too harshly going down the esophagus, suctioning sputum out of their lungs, anything like that. Okay, small cuts or abrasions. So what we can do with small cuts or abrasions, and I know certainly for our clients, we'll see that they have a skin tear. You know, their skin gets really thin as they get older. They lose that layer of subcutaneous fat. Their skin actually becomes like tissue paper, and so it tends to open up much more quickly than our skin does. So what we can do is we can help wash out that skin tear, soap and water. We can put some bacitracin ointment on it and cover it up with a Band-Aid or cover it up with gauze. What we cannot do is take care of a client who is on an anticoagulant or a blood thinning medication. And what happens is the reason that they're on that medication is because we don't want them to clot. Maybe they have a history of strokes, or maybe they have a irregular heart rhythm. So we don't want them to develop blood clots. Well, what happens then is if they're on this medication that would be called Coumadin or Eliquis, Pradaxa, Xarelto, anything like that, it prolongs their clotting time. And so they could really, really bleed out and lose a lot of blood if they're on that anticoagulant. So if you have somebody who is on Coumadin and has this cut or gets a serious injury, really pay attention to how much blood is coming out of that wound, and sometimes that really does entail a call to 911 to get their assistance with it. For wound care, again, we cannot do specific wound care. We certainly can't do wet to dry dressing changes. We can just do those little simple skin tear wound care. If it's a big wound that they're getting, they're going to the wound clinic once or twice a week or anything like that, we cannot take part in that. So we can't apply medicated lotion to it. We cannot apply suctioning to that wound, anything like that. That has to be done by a skilled professional or the physician in the wound clinic. Taking their vital signs, so taking their body temperature, their pulse rate, their respiratory rate. We certainly can take their temperature. What we don't want to do is put you in a position where you have to interpret the results. So what's a normal temperature? 37.0 Celsius, 98.6 Fahrenheit. We don't want you to have to look at that and say, oh my gosh, you know, their temperature is 38.5. What is that? So you can take the temperature. You could write it down if the family's asking you to take their temperature, their respiratory rate, their pulse, blood pressure, things like that. But we don't want to put that responsibility on you as the caregiver to be able to interpret those results to say, oh yeah, those are normal, no, those are abnormal. What are we going to do about it? So if you know how to take a pulse and a respiratory rate, absolutely fine. You can take it, you could record the results, but again, we don't want you to have to interpret those results and know, the parameters and what can happen or anything like that. Their blood pressure, they would have to have a digital blood pressure cuff to be able to have their blood pressure taken. You can assist with putting that cuff on. You could press the button for them and then just record what their blood pressure was. Again, it's like we don't want you to have that responsibility to interpret the outcome. Oh, that's way too high. Oh, gosh, that's way too low. Anything like that. So we want to make sure that, if the family wants this, maybe they have their mom or their dad has congestive heart failure. They need to take those vital signs every day, which is absolutely fine. A lot of times what will happen is when you take those vital signs and they are sent into the physician's office where either the physician himself or herself or the nurse will interpret those results and be monitoring the client from there. Glucose levels. So, yep, we have a lot of diabetic clients for sure. So what we can do is help the client set up the supplies to obtain their blood glucose level. What we cannot do is prick the client to get their blood level. So we can help assemble all the supplies that are needed. The client is the one who needs to be able to prick their finger and put the blood on the strip in order to put it into the machine, the glucometer machine. So once that blood goes on the strip, yep, we can help them because we can put that strip into the monitor, but other than that, we cannot assist them with anything else. We certainly cannot interpret what the outcomes are and respond with specific instructions. So a normal blood glucose level is 70 to 110. Let's say getting a glucose level of 650. They want you to be able to know what to do. Oh, yeah, if you get this amount, then give my mom extra insulin. We do not administer insulin. Giving too much or too little insulin can kill a client, and we definitely don't want that responsibility on you. Even if let's say their blood glucose level is 40 and they're unresponsive and no one has told you what to do, you need to go ahead and call 911 on that because they're not responding to you. The family should be around. If their blood glucose level is that low, they need to be able to respond accordingly and give that client some direct glucose. Medications in general. So medications need to be put into a pill box. So either the family members need to do it, maybe a neighbor, a trusting neighbor, anybody like that. We cannot have our caregivers putting medications into pill boxes, knowing that the trade name and the generic name might be different from what's on their list, and having to take responsibility for that. So reminding the client that it's time to take their medication. Maybe they have scheduled medication twice a day. Maybe it's scheduled once a day in the morning. Maybe it's scheduled 4 times a day, morning, noontime, evening time, and then bedtime. So those medications need to be clearly put into a medication pill box so that those meds are all in there and we are not responsible for monitoring to make sure that the correct pills are where they should be. Now, this does say that you guys can fill pill boxes, and I would just recommend that that's a lot of responsibility, and to call the office if you have somebody that they are requiring you to fill the pill boxes. It's an awful lot of responsibility to making sure that the right medication is in the right box at the right time, those kind of things. What we cannot do is crush or cut in half a pill or a tablet. even if it's a scored tablet and the client can cut that scored tablet in half. If it's not scored, that probably means that that medication in that tablet cannot be split, cannot be it has to be given all at once. So again, that's a huge responsibility to make sure that that medication is done appropriately. We cannot add or mix in medications with food or liquid. That would be administering medications. That already needs to be done by the family or a trusted neighbor or anything. And again, we cannot feed the client when there's medication in the food or in the liquid. And we certainly cannot dose medication. So taking a look at maybe a hospice client and saying, oh, he's really in a lot of pain. I think I'm going to give him double the dose of his Roxanol or his morphine to make him feel better. That all has to be pre-measured. It has to be given at the advice of, the hospice nurse or something like that. So I'm sure there are things that are going on that, you guys are asked to do to help clients out. We would really like to know those so that you are in a position where it's safe for you to practice your skills. Okay, providing prescription medication. Again, the pill box has to be in there, or Exact Care Pharmacy that has already pre-dosed them, whatever it is. We can verbally remind the client to take the medication. Oh, it's 9 o'clock in the morning. It's time for you to take your medication. Uh-oh, we missed your medication. Let's go back. If you miss a medication by more than 2 hours, I would ask you to please call the office. Sometimes medications have to be given exactly on time. If they're for a seizure that a client has, if they're for maybe a dysfunctional heart rhythm, something like that. We are unable to crush or cut in half tablets. Again, it was kind of like what I just said, making sure that the tablet is scored. If clients are asking you to do that for them, please let us know so that we can talk to the family members. And, usually I find that if I explain the safety issue that's involved in it, typically the client or the client's family understands. Again, we can't mix medications with food or liquid. We can't feed the client medication when we can't feed the client food when there's medication in there. And we certainly can't be dosing the medication for the client. Now, what we can do is we can, this is still on prescription medications, but we can give the client over-the-counter medication. So again, we can remove the specified dose from the bottle or the package, hand it to the client. Even those that take medications, maybe it's a swish and swallow, maybe they have a fungal infection in their mouth or anything like that. We can empty the compartment of a pill box into the client's hand or into their napkin or anything like that. We can steady the client's hand while they are giving themselves prescription medications. For instance, insulin. We absolutely cannot draw up insulin. We cannot dial up the insulin to make sure that that client is being covered with their glucose at a certain level. We can assist the client by just reminding them that it's time for their medication. Here's your pills. Where would you like it? Anything like that. We cannot assist the client with injecting themselves. So if they are taking medications for MS, say that they take it once a week, or they need coverage with their insulin, that client has to be able to draw up the insulin or dial it up themselves and give that subcutaneous injection to themselves. Okay, we can assist with prescription eye drops by placing the eye drops in the client's eye. We can assist with prescription eardrops by placing the number of eardrops in the ear. We can assist with nasal spray and putting the prescribed amount. What we cannot do is assist with home infusion therapy or home dialysis. So home infusion therapy would be, let's say the client is on prolonged antibiotic administration. So for whatever reason, they're going to go home and they're going to be on 6 weeks or 6 months of medication therapy through their port or through their IV. We cannot assist with that infusion therapy. We cannot assist with home dialysis. And currently, to my knowledge, I don't think we have anybody who is on dialysis at home. They typically will go to a center 3 days a week to get dialyzed. We cannot assess their symptoms or interpret their symptoms and to make a suggestion for the client to take or not to take prescription medications. That has to really be on the responsibility of the family or the client themselves. And then, of course, we need to document that appropriately, that the client determined that they didn't need their blood pressure medication or they didn't need their pain medication. Nebulizers. We can help with nebulizers. Typically, those nebulizers come with a pre-dosed vial, so we just open that up. It's a plastic vial. You twist it off and you put it in the nebulizer cup. We can turn on and off the nebulizer. We can rinse it. We can put that nebulizer into the dishwasher and make sure that it's dry. What we cannot do is measure medication. Decide that they need 2 doses of this medication and maybe half dose of that medication. Okay, so as long as it's pre-dosed, we can definitely help clients with your nebulizers. Over-the-counter medications, that makes things a little bit easier. Tylenol, Motrin, acetaminophen, which is Tylenol, ibuprofen, which is Motrin, naproxen, which is Aleve, Tums, calcium, vitamin D, anything like that. We can help them with over-the-counter medications. As long as it's over-the-counter, we can help that client who says to us, gosh, I'm really having a headache. I need a Tylenol. Can you go get me a Tylenol? Absolutely. If there's anything that they can take over the counter, we could definitely help them with that. Okay. Let's see, studying the client's hand while administering over-the-counter medications or vitamins, helping them with over-the-counter eye drops. Maybe they need re-wetting drops for their contacts, or they want to use drops that gets rid of their eye redness or anything like that. Over-the-counter medications and vitamins, again, anything that's over-the-counter, ear drops, eye drops, nasal spray, we can help the clients with. It's really anything that would be considered invasive to the client is something that we would stay away from in assisting them. Medication inhalers. So we can help the client. Maybe they are on an albuterol inhaler. Maybe they're doing a steroid inhaler. So we can remind the client to take that inhaler at their scheduled time. What we can't do, again, is dial it up, put it in the client's mouth, show them how to do the inhaler, anything like that. The client needs to have had that instruction either given by a professional or by family members or anybody else. Okay, insulin, what we can do. So we can get supplies for the client. There might still be some clients who need to draw up their insulin out of a multi-dose vial. Now, I cannot remember the last time that I have seen insulin in a multi-dose vial. Most of the insulin that I've seen, certainly in the hospital, it is in a pen, and you dial up the amount of insulin that's needed, and you put on the needleless cap, or what we call a needleless cap, and that client injects themselves with the needleless cap. And the thing about that is you have to wait a certain amount of time after injecting the client to allow that top part of the insulin to get into the client's skin. So there's no way, shape, or form that we are allowed to dial up that insulin, that we can put that insulin pen to the client's thigh or the back of their arm or anything like that. We can help them gather all their supplies, but as far as telling them how much insulin they need to cover their blood sugar with or their blood glucose with, we cannot do that. Okay, medication patches. What we can do is assist the client by opening up the package. We could help the client take off the patch that they've had on for the past 12 or 24 hours. We can assist them. Okay, it's 10 o'clock. That patch comes off and the new patch goes on. So we can definitely assist them, remind them. Those over-the-counter patches, even those that are prescribed um, for medication. Maybe they need it for, maybe it's a lidoderm patch, so they need it for pain. Maybe it's a nitroglycerin patch, so they need it to keep their blood vessels open. We can definitely remind them that it's time to change that patch out and help them do that. Definitely for anything that's over the counter, the icy hot patch, I think, is one. What's that green one that comes in a roll on? That now comes in a patch. We can assist them with doing that. Again, though, we cannot prescribe, we can't make comments or recommendations like, yeah, why don't you try this icy hot? That would be really good. If the client suffered a complication from it, we would be liable for that. Okay, that ends the presentation on our scope of practice. And please reach out if you have any questions. I know for me, some of them I was a little bit surprised at in terms of, I always thought that we couldn't even give over-the-counter medication, and we can. So I hope this was as informative for you as it was for me. Thank you so much for doing a great job and taking such great care of our clients. We appreciate you. We appreciate your service. And gosh, I'm really looking forward to seeing you all in person again. Have a great day.